Welcome to the recorded version of Preparing for Loss, Death, Dying, and Grieving, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Homestead Senior Care.
All right, we have two presenters joining us here this morning. Lakeland Hogan is gerontologist and caregiver advocate for Homestead Senior Care. Lakeland works to educate professionals, families, and communities on issues older adults face. Lakeland is a doctoral candidate at the University of Nebraska-Omaha, where she is studying social gerontology. She has a Master of Arts in Social Gerontology and a Master's in Business Administration from UNO. Lakeland has professional experience in the private and public sectors of senior care services. She has worked on special projects for UNO's Department of Gerontology and the local area agency on aging. Lakeland serves as Vice President of the Board of Directors for the Dreamweaver Foundation and is also active in the Alzheimer's Association's Walk to End Alzheimer's. Lakeland has a passion for helping others, especially aging adults and their families. Also joining us this morning is Julie Masters. Julie is professor and chair of the Department of Gerontology at the University of Nebraska-Omaha. She also holds the Terry Haney Chair of Gerontology. Julie teaches courses on the UNL and the UNO campuses and works with honors and graduate students interested in end-of-life issues. Her research interests include health aging, end-of-life planning, and caregiving. And with that, I'd like to turn the floor over to our presenters here this morning. Lakeland and Julie, welcome.
Thank you so much, Steve. Hello, everyone. Thank you so much for taking the time to join us today. I'm really looking forward to our discussion. And while today's topic might be a difficult one to talk about at times, I feel like it's not talked about enough. We know that death is a normal part of life, yet as a society, we don't always like to face the inevitable. And now, living in today's day and age, and because of COVID-19 or the coronavirus, we're hearing more and more about death, and we might even be found contemplating our own mortality. We're also most likely dealing with various types of loss, so I think today's topic is very prevalent. And for some of us, that might just be a loss of our routine. It could be the loss of a job, but it could also mean losing a loved one, family member or friend. And as loved ones are passing, family caregivers right now, because of social distancing or other safety measures, family caregivers might not be able to be with their loved ones at end of life. And those traditional outlets that we usually have as a society for grief and for support might not also be available to us because of physical distancing and social distancing. So today I'm really grateful to all of you for tuning in for a discussion around this topic. I'm also very grateful to have Dr. Julie Masters with us. You'll be hearing from her in just a bit. I've taken her course in my graduate studies on death, dying, and grieving, this topic, so she is an expert and knows a lot. So I'm excited that you'll be getting to hear from her in just a little bit. And we hope that all the information that you take away from today will help you as you work with family caregivers and as you work with older adults in your daily lives. And it could even be applicable to your own families. But before we jump in, I did want to just go over the objectives quickly for our webinar today. We're going to be talking about why death is such a taboo topic in today's society, but also talk about the importance of planning for end of life. And especially as families are impacted by COVID-19, we're seeing even more so now the importance of planning in advance. And then also, it's really important to make sure that the older adult is included in the conversation, that their wishes are known, and we'll talk more about that. And then there's also options available for care and support at end of life that families might not know about or may want more information on. So we'll be going over those options. And then finally, we're going to be wrapping up with some resources that you can take away with you as you plan for the grieving process. So first, before we get started, I want us all to reflect on this question. What if we treated death like we treat birth? There's a great TED Talk by Jane Whitlock. She's a death educator and end-of-life doula. And on her TED Talk, she poses this question. If you want to go out there and watch it, I highly suggest it. But she asks throughout her TED Talk, what if we treated death like we treat birth? I apologize about the slide. She says, what if we shared stories about death? What if we had go-to books like What to Expect When You're Dying? She says, what if we held a death shower like we would hold a baby shower, where we give blessings and read poems and surround the person with their family and friends? We create a playlist. And what if we would create crafts to process our anticipatory grief, or we're able to prepare ourselves for what was to come. So when I first watched this, I had to admit that when she said, what if we treated death like birth, it made me chuckle a little bit. But I think that there's some good food for thought there. And then she wraps up by saying, if we treated death like birth, death would take its rightful and valued place in the circle of human experiences. And again, death is a part of life, but yet as a society, we tend to fear death. We don't want to talk about it. Family caregivers don't always know how to bring it up to their aging loved one, or the aging loved one might want to talk about it, but family members might not be open to the conversation, or they might be hesitant to engage. So that's why I think as professionals in the aging space, it's really important for us to talk about end of life and planning for end of life, so it doesn't become or doesn't remain as taboo as it is today. But in a survey of older adults at Homestead Senior Care, we found that older adults are more comfortable planning for their funeral than the years leading up to it. And if you think about it, we see commercials on TV for planning your own funeral and picking out the casket and, talking about the service. But the years leading up to the end is really not talked about as much. And really that's where it's important for families to engage in discussion so that they can understand what their loved one wants. And then when time comes to make decisions, the family's already had those important conversations. So hopefully it helps those family caregivers make decisions a little easier, or eases the burden of those decisions because families have already talked about it. But the reality is that a lot of people haven't talked about this, so when the time comes and or if there's a crisis, family members are left wondering, what would my loved one have wanted? And then that can create some stress, and later on it could create some guilt. And so hopefully we can help families again engage in this conversation sooner, so that they can again know their loved one's wishes. So some additional research that we found when we did a survey of older adults at Homestead Senior Care, we found that 90% feel that it's important to talk to loved ones about end-of-life care, but only 27% have actually taken the time to do so. And about 80% said that they want to talk with their doctors about their wishes for medical treatment towards end of life if they were to become seriously ill, but only 7% had that conversation with their physicians. So people are recognizing that, yes, this is an important conversation to have, but then when it comes to the execution of actually maybe putting a plan together, filling out some of the important paperwork, less people have actually taken those steps to do so. And then we also found that 52% would ask their doctor to stop treatment if they had an incurable disease and they were totally dependent on others for care. So if about half of these people are expressing that would be their wish, but if they haven't made a plan for that, then that physician might not know that that is their wish, and they might make healthcare decisions that aren't in alignment with that. And 35% of older adults say that they would tell their doctors to do everything possible to keep them alive, even if that meant a great deal of pain or no hope of improvement. So again, people know what they want, but unless they have that conversation with someone else or put that in writing, it's very unlikely that that wish will be able to be carried out, because again, it's important to express those wishes and to make those wishes known. Other research has shown that a third of adults 18 and older, and approximately half of adults 65 and older have completed formal advance directives. And we're going to be talking more about those important documents that come along with end-of-life planning, but only about half of older adults have actually completed those formal pieces of documentation, which again is so, so important. So we know also when it comes to death and dying that there are some common myths, especially around hospice care and around palliative care. And so I wanted to kind of go over some of these myths and debunk them, if you will. So first, often people think that hospice is a place. And I find that, well, first of all, this is false. Hospice is actually a philosophy of care and can take place wherever really the need exists. So that could be in a home, or it could be in a senior living facility, nursing home. There are also some hospice facilities that focus specifically on hospice care. And we know that during COVID-19, during this coronavirus, hospice care is still taking place. And so again, hospice isn't necessarily a place, it's a philosophy of care. And then some people think that palliative care is the same as hospice care. Sometimes these two terms are used interchangeably, and although palliative care and hospice care share some of the same principles, comfort and support, they are different. So I'll be going through a little bit later and talking more about those differences. There's also a misconception that hospice care is expensive, and for those 65 and older that are on Medicare benefits, on Medicare there is a hospice benefit, and for those under 65, most insurance companies will cover it. So if cost is a barrier, we want to make sure that families understand that that shouldn't be as big of a barrier as they probably perceive in their mind. There also is this notion if a person accepts palliative care, that they will not receive treatment. And that is also false. Palliative care is often given in addition to a prescribed treatment. So if somebody is diagnosed with cancer, as they go through their cancer treatment, palliative care might also be integrated into their care plan to help manage the symptoms that are accompanied by that cancer treatment. And then there's the myth that hospice is only for the dying person, but that is also false. Hospice also is a support system for the family of the person that is dying. They focus on supporting that family and offer services and support to them during the hospice process and then after. So I'll be talking again more about that in just a bit. But I do want to pass it over to Julie to talk about ways that we can start this conversation around end of life. So I'm going to pass it over to Julie now.
All right, Lakeland, thank you so much. And thanks for the opportunity to visit with folks about thinking about end of life and what that entails. And so one of the first things to really get the conversation started is really to think about your own life and to think about the person that you're caring for. What your personality may allow or afford you to consider may be very different than someone else, and recognizing that each person has their own preference. So taking that into consideration. Looking at the big picture means looking at, what is it that I want to accomplish before my life ends? What is it that is going to be important to me in terms of my own care and concern as it relates to my own health? Thinking about people who can help you plan. One of the things that I do as part of my death and dying class is I have students complete a death plan. And it really includes everything from not only what kinds of health care services do I want to receive, but what sorts of messages do I want to impart to my family members so that they know what matters most to me. Thinking about our finances. We know that there's some research that suggests that people spend the most amount of money at the end of their life in terms of care. Now, it could be that isn't the way that you would want your finances to be spent. So putting that into consideration. Creating a planning guide, and similar to the death plan that my students complete, it's about creating a plan that says, this is what I would want done or not want done. And then thinking about a bucket list. And I really like this because for some of us, there might be things that we want to accomplish maybe not as grandiose as jumping out of an airplane to skydive for the first time in your life, but maybe it's resolving issues that you might have with a family member or friend that you want to get resolved before the end. So thinking about where can I find assistance as you put together really a team of people to help you with end-of-life planning. One might be consulting with your own attorney if you have someone like that in your life. Another might be reaching out to the legal services that are part of the Area Agency on Aging that is in your area. And your Area Agency on Aging, which I'll refer to now as the AAA, is a wonderful resource when you're looking for additional information. You might also think about legal aid, and particularly if they have something like an elder access line, might be another place in terms of resources. Speaking with a financial planner, and for some folks they may think, well, I don't have enough wealth or resources to visit with a financial planner. That couldn't be further from the truth. You want to be able to engage people that can help you think through how to best use the monies that you do have available, however great or small that might be. Speaking with a funeral director is also a wonderful idea, particularly when you think about the cost for whether it's a funeral or a memorial service. Really sitting down, visiting with this person to find out what services they can and cannot provide based on the resources that you have, and then looking at care options. You know, it's interesting, we tend to make pretty significant decisions in crisis situations because we just didn't have the chance to think about it. But if you talk about or research other care options that might be available in the community, when you do need those services or resources, you'll be better able to make those requests. So some important conversations that people think about when they're faced with end of life. One thing is making sure everyone understands what you want, especially those people that you might designate as your healthcare power of attorney. It's not just a matter of putting their name down on a sheet of paper and saying they'll handle it. It's really about letting them know this is what you'd want done or not want done. Some of the research that Lakeland alluded to also talks a bit about how healthcare proxies sometimes find themselves in an uncomfortable situation because no one sat down and really talked about what the person would want or not want. And so the sooner you can have that conversation, the better. Finding out about medical options. Now, I really appreciated what Lakeland had to say, not only about hospice, but palliative care. And when we know that those are options that are available for us to help our last days, our last weeks, and frankly, our last months, because hospice is 6 months or less to live, when we're given that chance to receive the sort of care that brings us the most comfort, it really leads to a great success. We've already talked about financial goals and what those might entail. Engaging a spiritual advisor, thinking about particularly if you're a person of faith, who you can talk to about what's appropriate within your particular faith tradition in terms of receiving services and support. And asking that person not only to be with you on that journey today, but over the course of your life. And then conveying your wishes to your care team. That's letting your physician, your nurse practitioner, your healthcare provider know what you would want, particularly when you're in good health, that you've thought about this, and should you become in poor health, that they are ready to know and to act on your wishes. So what it means to live well. And think about this. In my class, I tell my students this class really isn't death and dying. It's about life and living. And when we look at it from that vantage point, then we see that it's about living well is including things not only about what do I want done today or tomorrow, but right up until the end. It's really about beginning with the end in mind. we also believe that when people face death, they can also face life. Because when I've really thought about my dying and my death, when I've really thought about my mortality and what that means, the things that now really matter take the place of kind of the frivolous things that just occupy our time. We're now more focused on the message and the meaning behind our lives. I think it's also about, when we talk about living well, it's about thinking about our preferences and the decisions that we want made for us should we not be able to make those decisions. Again, the more that we can have those conversations, the more that we can let people know what we want or don't want is key. And then asking ourselves, where am I in my life? Am I really at peace with myself? Am I at peace with my life? And are there other things that I could do or accomplish that could make life better, not only for me, but also the people that are in my life? So I'm going to stop here and turn it back over to Lakeland so she can talk a little bit more about the things that matter most.
Thank you, Julie. So I appreciate Julie's information that she just provided, what it means to live well, especially up until the end. And a lot of that is the services and the support that the older adult has and that their family has through that end-of-life process. And so we're going to be talking now about those services and nearing the end of life's journey. So we know that for older adults, there are common medical conditions out there that we see that follow a person till end of life. So when looking at the CMS data, the conditions that you see on the screen are conditions of those that are enrolled in hospice services. They're not in any particular order, but cancer has historically been thought of as the main reason for hospice use. However, conditions that are becoming more common include heart disease, COPD, Alzheimer's, and other types of dementia. And to clarify, these diagnoses or these conditions does not automatically mean when the person is diagnosed with COPD, then they need hospice. That's not the case. But people can live a long time with these various chronic conditions, years or even decades. But these conditions commonly progress to an end stage. At that point of end stage, it's often believed, or the medical practice is that more treatment might pose a burden rather than a benefit. So at that point, they're entering end of life, and a referral to hospice care might be made at that time. Or as the person is living with the disease, palliative care might be introduced to help reduce some of the symptoms of these diseases. So again, these are some of the common medical conditions that we see among those that are using hospice and end-of-life services. But again, they're not in any specific order on the prevalence. So when we look at options for end-of-life care, I'm going to go through the following. So we're going to talk more about palliative care and hospice care. We touched on it a little bit, but family caregivers are also a large part of end-of-life care for many older adults. A lot of the responsibility falls to the family caregiver, so we'll talk more about that. And the importance of respite and getting a break even during that end-of-life stage. The amount of care that families take on can often be quite burdensome. So getting a little bit of respite or time away, some extra support can be really helpful. And then we'll talk about home care and the role that home care can play in end of life. So we'll start by talking more about palliative care. And as I mentioned earlier, palliative care is different than hospice. And this can but they share some of the same principles, as I mentioned earlier, of comfort and symptom management. But palliative care and hospice care, those can be confusing terms for family caregivers and for the patients themselves. Palliative care, again, can be best described as pain relieving or comfort care. People of any age can receive palliative care for serious illness, whether it is life-threatening or a chronic condition or life-limiting illness. But the goal of palliative care, again, is to improve symptoms and help relieve pain and the stress that comes along with with the condition that they're facing. Some of the areas of focus, again, are the same as hospice. And if a person is no longer receiving curative treatment, they might transition from palliative care to hospice care. And I mentioned earlier the example of someone who's diagnosed with cancer. They might be going through a lot of treatment that has a lot of side effects, and so palliative care might be introduced while they're getting chemo or radiation to help control the symptoms and to ensure the goals of the individual are being met. A lot of times, I watched a great documentary about pediatric palliative care recently, and the palliative care doctor was talking about how there's so many people or medical professionals involved in the person's care, and oftentimes we see that in older adults. There might be a cardiologist, and there might be a geriatrician, and then there might be a few other doctors involved, depending on the number of chronic conditions, and they don't always communicate. So sometimes palliative care is that kind of communicator that really helps to make sure that the goal of the patient is being met and that all of the medical professionals are on the same page. And for someone, if their treatment is successful, again, back to this example of someone diagnosed with cancer, if their treatment is successful, then their palliative care journey might end and they might go back to their everyday lives. However, if they're going through cancer treatments and the medical professionals realize it's not successful anymore, this might be the person's entering into kind of their end-of-life journey, then hospice care, transition to hospice care might take place at that point. So again, hospice care and palliative care, they are similar, but often families get confused. I get the question all the time, how is palliative care paid for? And most private insurance does cover palliative care, and when it comes to Medicare and Medicaid, the cost might be covered, but it's really important for the older adult to understand their coverage and any copays that might come along with it. So now let's talk more about hospice care. So I talked about the myths of hospice care towards the beginning of our presentation, but hospice is a service, again, that's generally misunderstood. Enrollment in hospice requires a prognosis of 6 months or less, but a lot of people think if my loved one's put on hospice, it's going to speed up the end-of-life process and it's going to make them die sooner, or maybe it's going to postpone their death, and that is not the case. Again, it's focused on pain and symptom management and reducing the stress of serious illness during the terminal phase. And it often, again, it can occur in a variety of settings. And some research shows that someone on hospice care or on palliative care might even end up living longer than they would have because their symptoms are well managed, and it can help lead to a better death, which is something that people don't always use that term, a better death. But really hospice, I've heard families say, I wish I would have used it sooner, because we often see that people enroll in hospice kind of late in the game, if you will. Over half enroll in hospice for 30 days or less. Yet people can start enrolling in hospice when they have 6 months or less as kind of a prognosis. So really there is a great benefit to hospice care. And for many families, this can kind of be scary to admit that their loved one is in need of hospice care or could benefit from hospice care. So as professionals in the aging field, it's important to convey the positive aspects of hospice care and the support that it can offer, not only the individual as they are passing away and going through end of life, but also for the family, for that support, emotional support, and also the physical support that comes with it. So to touch a little bit more on hospice care. Again, it involves medical care and equipment. Often, if you're receiving hospice in a home setting, they can supply things such as a hospital bed that might make it easier for the family to provide care in a hospital bed versus a kind of conventional bed. Other equipment that they might need, the medication that the individual might need, such as morphine towards end of life. But they're also providing emotional and spiritual support. Often they have clergy and social workers available to really come around the family caregiver. Often the majority of care and support does, again, fall to the family, as I mentioned earlier. And so this interdisciplinary team really rallies around the patient and the family. And I like this graphic here. It kind of illustrates who all is involved in that care team. So for both hospice and palliative care, it really is a team approach. And as I've worked with hospice companies in my career, I really do find this to be the case. They really do take that team approach with the person that is actively dying or the person that needs treatment in the middle along with their family. And then all of these professionals are working as a team to really support the family and the patient. So there are often nurses and physicians, the hospice staff, social workers, often a chaplain to support from a spiritual and emotional standpoint. And then you have, the family caregivers that are supporting. And also, depending on the needs of the individual, there could be other therapists that are involved, counseling services. Often hospice volunteers are brought in for companionship or to give a little respite to the family, along with professional home care. They can come in and take care of some of those, the day-to-day needs of the individual if the family is not able to, or to just give the family a break. So again, that's what I think one of the great benefits of hospice care and palliative care is the whole team coming around the patient and the family to provide support. And again, that family caregiver really plays a vital role in end of life. Hospice staff is not often there 24/7. They're in and out of the home throughout the day, throughout the week to provide care. And of course, in crisis situations, they're there to provide support. But really, families fill in when those hospice members aren't there. And so the demand on the family caregiver we're finding is really increasing. And that's true for family caregiving across the board. They're doing tasks such as the personal care of their loved one in end of life. They also have a lot of times the household tasks. They might be taking on medical or nursing tasks, such as administering morphine to their loved one. And so they're really involved in that medication management as well. So you can imagine as a family caregiver, especially if they've never had a family member or a loved one pass away before, this could be a very overwhelming time. And I've worked with family caregivers over the years in a variety of settings. And, again, it can be very overwhelming. But that's one of the great things about hospice, again, is it comes, wraps around the family and offers support in various ways. And the respite that can come along with the hospice volunteers is great. As part of hospice organizations, they're required to have a volunteer program. So it gives the family members an opportunity to step away from that caregiving role for a moment, or to just be beside their loved one and be present and really spend that quality time. An opportunity for them to kind of recharge their batteries. And this respite, again, can be provided by hospice volunteers. Family members or friends can come over and be with the older adult or the loved one while the family gets a little bit of a break, or professional in-home care is also an option. Services that are provided by professional in-home care are provided by trained caregivers. They often can support not only the individual, but also the family. And they can assist with things like that personal care, medication management, those everyday tasks such as preparing meals and keeping up with the house. I know I worked with the family, and the son was very overwhelmed by the personal care that his father was requiring. He was bedbound and was needing help changing his adult briefs, and the son was very overwhelmed. And so he was happy to have the home care professional support in that task because for him at that time, that's not something he was comfortable helping his father with, not something that was something that the home care professional could do to kind of ease the burden on the son and allow the son to have that quality time with his father at end of life. So it really does depend on the family and their comfort level with providing care at end of life to their loved one. But again, the support that hospice can provide in palliative care and home care and hospice volunteers, it's really wonderful. And again, many family members say, I wish we would have called a hospice sooner or engaged in these services sooner. And the beauty of hospice care is they often have bereavement services that follow family caregivers through the grieving process, because it is an emotional experience, the end of life process and the grieving process. So I'm going to pass it back to Julie to talk more about that emotional experience.
Lakeland, thanks so much. You know, when we think about end of life, just in general, without being in the midst of COVID-19, it can be a very emotional experience. And I think now with COVID-19, it's even heightened in terms of concerns that maybe we haven't planned appropriately, maybe we haven't shared with our family and our care providers what we would want done or not want done. So again, that puts family members, it puts care providers, it puts medical providers and so on in a position of what should we do, what would this person want, and so on. So thinking about how do you support people's emotional needs, one is about, you know, being honest in terms of what the person would want or not want done. It's also about being non-judgmental and recognizing that, you know, what we're seeing show up in the press, in the literature, is people who are expressing their wishes to say, you know what, I just want comfort care, or I just want you to make sure that I'm taken care of in a way that doesn't take away resources from someone else. And it's been kind of interesting to hear people really be able to say, this is what I'd want done or not want done. Perhaps that's one of the benefits of COVID-19 is it's prompting all of us to really talk about our end-of-life wishes. You know, allowing silence too can have great benefit when we think about people communicating their wishes. There's wonderful, there've been some wonderful quotes that have emerged in terms of the value of silence. One comes from the book, The World According to Mr. Rogers. And what he has said is, you know, as it relates to silence, is this idea that the purpose of life is to listen. It's to listen to yourself, to your neighbor, to your world, to your God. And when the time comes, to respond in as helpful a way as you can from within and without. And what's curious is when we stop and listen and really listen in terms of what a person would want done or not want done, we find that they're able to fully express their wishes. And then I think the other thing is respecting a person's space. You know, Lakeland did such a beautiful job in talking about the benefits of hospice and palliative care, and that hospice as a philosophy of care says, I can receive that care in places that might be most familiar to me. And that might be in someone's home, or it might be in a senior living community or a nursing facility, but it's a place where that can provide the most support to them that they need. So again, respecting that person's space, not only the physical space, but also their emotional space, what they would need or not need in terms of their own care. Now, one of the things when we think about loss is this sense of grief. And I just want to make sure to distinguish there's grief and then there's mourning. Grief is this passive response that happens so that when we've experienced loss, and particularly now with COVID-19 where people are ill for a short period of time and then die as a consequence of this disease, it can be very overwhelming for families because they have this sense of grief of this idea that they weren't able to accomplish everything that they had hoped. There have been a couple of models of grief that we think are interesting to share with with all of you participating. There's always the model that you hear people reference, and that was the work of Dr. Elizabeth Kubler-Ross, who really came up, it was originally the 5 stages of dying, but then adapted to grief by Kessler and others. But this sense of the stages of grief, of denial, denying this person is lost from my life, and the challenges that I'm feeling because of it. Anger, because the person may not have taken as good of care of themselves as we would have hoped. Bargaining for something else. Depression, the sadness that can be associated with the loss, and then acceptance. And then there's another group, and this is tied to mourning. So while grief is a passive response, mourning is active. And I like the work of William Worden and use this in my class because I think it kind of puts in a little more flexibility in terms of how we progress. But he talks about first to accept the reality of the loss, this idea that this person that we love is no longer with us. And if you've been married to somebody for 40, 50 years, and then to have them die suddenly, just this sense of discomfort or kind of this sense of kind of being off balance because this person has always been part of your life. You know, it's that idea that you go to pick up the phone to call this person and you catch yourself and you say, wait, I can't do that anymore. To processing the pain of grief, anytime we've lost someone or lost something in our lives, we grieve over that, and it takes time. To adjusting to a world without that person, the person we've looked to make financial decisions maybe for us, or keeping the household running and so on, that now that's on us. And then what I think what Worden has done with this last stage is talking about an enduring connection with a person who's died. The thing is even though someone may not be physically present with us, they always remain with us through the lessons that they've taught us or through the experiences that we've had. And by the way, those experiences could be good or bad, but nonetheless making an influence or an impact in terms of how we look at life. So there's some things that can support us in terms of grief and loss, and that includes such things as spirituality. Now, spirituality is not necessarily tied to a particular faith tradition as much as it gives us a sense of connection to something greater than ourselves. It also can give us a sense of purpose. So that's one way that we can address grief. Another is going to those more traditional sources of support, our religious traditions. It's interesting when I think about the different faith traditions, particularly within the Jewish faith, of sitting Shiva and the benefits to that, to within the Roman Catholic tradition of the anointing of sick, to other faith traditions that provide us the support we need when we're going through this period of transition, not only for people who are dying, but then once death has occurred, through their own grief and mourning. And then having a sense of faith or trust in other people, in things, or a divine being, whatever that is to the people that you're supporting or even in your own life can have great benefit. And then when we think about this spiritual experience, it really comes down to a matter of reflection. And goodness, if anything, COVID-19 has prompted some of us to just sit back and reflect on what that means, or this person that we love so much who may have just died suddenly, what did their life mean? And being able to put that into perspective. For some people, there's a question of where will I go after I die? Some people believe, for instance, in the humanist tradition, that we don't go anywhere else, that this life is it. And the way we leave our mark is through our legacy. Whereas for others, it's what can I do to live a life that will allow me to achieve a different state of being. And then will my family be okay? Will my family who have always looked to me for support, are they going to be able to continue on? And then finally, what unfinished business do I need to complete? Unfinished business can be things such as, making amends with people, or making sure I have everything organized so that when I do die, it makes it a little lighter or easier on my family. There's a beautiful book by Ira Byock, a hospice and palliative care physician, and the title of it is The Four Things That Matter Most. And what Dr. Byock noted in terms of his interaction with people at end of life, he said, it's not about money or possessions or all those things, but it's about relationships. And then what people would say is the things that matter most are to be able to say to someone, please forgive me. Perhaps you're all the exception on this call, but I would say in my own life I've made quite a few mistakes. And so it's about reaching out to people to say, forgive me for my failings. To also being able to say, I forgive you. When we hold something against people, that can bring us down, have an impact in terms of our own emotional well-being. So to be able to say, I forgive you, to say, I love you, how important that is, because that's, and when we think about the memories that we leave with people, I love you is one of those messages that will sustain people for the long run. And then to say thank you. Thank you for being part of my life. Thank you for allowing me to really grow as a person. All those things have great benefit. And then when we think about families and their own self-care, it becomes important to accept the feelings that we have. Some days, and I know when I was a caregiver a number of years ago, there were days where I would be frustrated or not sure I was doing the right things, but to recognize that those are very normal. So to accept those, to realize we'll have a range of emotions. Sometimes that emotion that can be the most important to us is just being in the moment, to appreciate this moment we have with our loved one. Recognizing other people may feel the same way we do. There's a beautiful book by Nancy Cobb, and the title of it is In Lieu of Flowers. And she says, if you give yourself permission to talk about your experience, you'll find that other people won't want to talk about theirs. And this is kind of tied to this idea of sharing our emotions with others, maybe through more practical things such as a support group, but even sharing our emotions with our family members. Not being afraid to ask for help from other people, and for people that are used to doing it on their own all the time, sometimes when we ask other people to help, it allows them the chance to have some meaningful moments with the person that either we're providing care for, or maybe for us once death has occurred of our loved one. Not judging ourselves. I'm always intrigued when I've worked with caregivers in terms of research projects. The ones that said or will say they haven't done enough typically are the ones that have done more than enough. And then taking a break when needed. Sometimes we think about things and we immerse ourselves so heavily that it weighs down our hearts. Sometimes we just need to take a break. Maybe it's taking a walk around the block. Maybe it's just taking a moment to look out the window and appreciate what's in front of us, but it can provide us a great deal of support. And so I'm going to pass it back to Lakeland so that she can share with you some additional information about resources that are available.
Thank you so much, Julie. I do have some resources here on the slide. I know Dr. Masters has referenced several great books, and there's so many wonderful books out there on this topic, but wanted to just leave you with some resources. The National Hospice and Palliative Care Organization has some wonderful information. I want to point out the 5 Wishes and the Conversation Project. Both of those sites can help families really plan for end of life, and goes over the important documents and ways that families can go about sharing that information with the people that need to know those end-of-life wishes. And then also on this website, or this resource slide, there's your local area agencies on aging, which we've mentioned. There's also
Strength for the Moment. It's a great faith-based or community for family caregivers. We know those dealing with a loved one or those caring for a loved one with Alzheimer's and other dementias create some additional challenges. So the Alzheimer's resources listed there can be helpful. But I think we'll open it up for questions in just a moment. But before we do, Julie, I thought maybe we could just comment as kind of a wrap-up before questions. This topic of death, dying, and grieving, we've mentioned how the coronavirus, COVID-19, has impacted us all in various ways. And there are a lot of family members right now who are not able to be with their loved ones as they're passing away. And my heart goes out to all those caregivers. Maybe there's some of you on the call today who've lost a loved one and maybe have not been able to be physically present with them or to go through some of what we've just talked about. And now they're in the grief stage, and grief looks a little bit different right now. So, Julie, do you want to, maybe we can just talk about that for just a couple minutes before we open it up for questions. I know when I created this PowerPoint a couple months ago, COVID-19 wasn't really even on our radar yet, and now it's really changed all of our lives. So do you have any initial thoughts for those out there that are going through this?
Well, I think about, and I would agree with you, my heart goes out to families too who can't be present with folks who are spending their last moments maybe in a place that they didn't expect. My heart also goes out to all the medical professionals, the healthcare providers, the professional caregivers who really are being with people in their last moments of life, those grace moments where someone, passes from this life, and that sense of being there. Just what a difficult time that is for so many different people. I think this new way of facing end of life is about something that researchers have talked about in terms of complicated grief. And so it's not just as business as usual, and we get to go to say goodbye at the mortuary through the visitation or the wake and then the funeral the next day. We now are finding ourselves in uncharted territory. I go back to times in history such as World War I, World War II, where people died and families couldn't be there, and so they had to figure out another way to remember or honor that person. And so I would encourage anyone who has experienced the death of a loved one to begin thinking about what can we do to honor this person later on. Sometimes you hear people refer to as celebrations of life, and those can be done with or without a body present. Certainly those things can be done. Thinking about ways to remember that person, maybe on the anniversary of their death the following year, might also be useful. To think about maybe having additional ceremonies, either faith-based or not, but again, as a way that not only can they honor the person that has died, but to begin to find ways to comfort themselves as well as they say goodbye.
Julie, thank you so much for those thoughts. And I think that those are some great thoughts and suggestions and ways that we can hopefully still honor the lives of these individuals that we've lost. And so thank you so much for that. And so I know we have a few minutes left, and Steve, we'll turn it over to you now for questions.
Okay. Thank you very much, Julie and Lakeland. Great presentation, a very important topic. And yes, everyone's time for Q&A, so send in those questions, and let's just jump right into it here. Lakeland and Julie, first question for you. Beyond lack of accurate information or misinformation, what are the most significant systemic or institutional, community, cultural barriers to patients or families embracing palliative or hospice services earlier than they typically do in one's end-of-life journey?
Lakeland, do you mind if I jump in on this?
Please, yes, that's a great question.
First of all, Steve, that is an outstanding question. So whomever asked it, thank you. I think systemically, we maybe haven't done the best job in understanding what different cultural traditions expect in terms of end-of-life care, and we could do a far better job of bringing people the information that they need so that they can make informed decisions about what they would want done or not want done. You know, it's also about addressing the myths that we might have about, and Lakeland alluded to this earlier, but the myths we might have about hospice care. Hospice care does not mean that we're going to abandon you or leave you alone, but what hospice care means is we're going to support you to the end. Palliative care is something else that also is available to people, but again, we need to do a better job of educating people of the benefits. And so I think after we get out of under the cloud of COVID-19, I think as just not only nationally but internationally, we really have to give some more serious thought to finding ways to better communicate end-of-life support.
Okay, thank you. Next question. I have never heard of the stages of grief referred to as passive. Can you talk a little bit more about that?
Well, and I can. So grief itself is passive. Grief is something that happens to the person. You don't make grief happen to you. Mourning, on the other hand, is an active process. So mourning means, for instance, writing the acknowledgement cards, finding ways to remember that person through different ceremonies and so forth. So grief is passive, whereas mourning is active. And I probably could have done a better job of introducing those, but I hope what I've said has just clarified those two concepts.
Okay, thank you. Next question. How do you access palliative care if you are not in a hospital or a nursing home?
So palliative care
go ahead.
would go ahead. No, go ahead, Lakeland. I'll let you take that one. Pardon me.
Oh, you're fine. If you're not within a hospital setting, that is a great question. There are organizations that provide palliative care in the home setting as well. So reaching out to your healthcare provider to see if there is a palliative care organization within the community that offers palliative care is a great step. Julie, what else would you suggest?
Well, and I think it goes back to these conversations that you would have with your healthcare provider, so your family practice physician or nurse practitioner, to be able to say, tell me a little bit more about how I can get plugged in. Tell me a little bit more about how I could get a referral to a palliative care specialist so that, you know, my symptoms are better managed. So it's about making sure that there's an open communication with your healthcare provider, I think would be a good next step.
Okay, thank you. Next question. Do you have any suggestions or resources for families who are caring for a dying loved one at home, but they're not comfortable letting hospice workers into the home at this time?
So, Lakeland, let me jump in and then
go ahead.
We can go from there. You know, I think, and I can understand why families would be reluctant to have somebody come in the home, particularly if that's not what they've done before. So it's really thinking about hospice is not just about providing the support to the person, but also to the family. So if hospice isn't what's needed at the moment or wanted at the moment, then what other sources of people in your life could you turn to as you're finding yourself trying to make decisions going forward? So earlier we talked about people from different faith communities. And so it might be reaching out to your rabbi, it might be reaching out to your imam or your priest or your minister or something along those lines, someone that can help you walk that journey or make that journey. I think the other thing is reaching out to more traditional sources, and Lakeland did a beautiful job of talking about people such as area agencies on aging, to see if they might have a care manager who might be able to also assist in brainstorming or thinking about other resources or support.
I think the benefit of hospice is it can connect you to a wide array of resources to help you continue in your role. So if you don't want to go down the hospice path, which is fine and absolutely fine because that's a choice, it's making sure you have another place that you can go to for resources.
Okay. Well, Lakeland and Julie, we have reached the end of our hour here, and unfortunately we're out of time today, but I want to thank you for joining us and presenting on this very important topic. Thank you so much.
Thank you. Have a great day, everyone.
Steve, thank you. And to everyone who's providing care, know of our extreme gratitude to you for giving of yourself in such a selfless and generous way.